Thank you again. Good evening, everyone. Welcome. We are so glad that you could join us tonight. On behalf of our entire team here at Colorado Urology, we want to thank you for taking the time to be here. My name is Angie. I am the physician liaison for Colorado Urology. Here at Colorado Urology, we're always looking for ways to bring valuable health information directly to our patients and to our community. So we like to host these webinars. So we believe that our patients should have access to great information from our experts. So we're very excited to have our very own Dr. Ali Saram here with us tonight to talk about BPH. We know there's a lot of questions and a lot of confusion when it comes to prostate health, and it can be a topic that creates even more questions. And so tonight, our goal is to provide helpful, straightforward information and give you an opportunity to learn a little bit more from a physician. So whether you're currently dealing with the issue yourself, supporting a loved one, we want you to learn more. So we will have some time for questions at the end. So as questions come to mind, please feel free to submit them either in the Q&A box or in the chat, and I'll get those and we'll hit those at the end of the meeting. So thank you again for spending your evening with Colorado Urology. And with that, Dr. Saram, I will turn it over to you.
Thank you very much, Angie, and many thanks to everybody who has taken time in their evening to attend this webinar. I always say if you can't make it through this hour because you have to go to bathroom, let us know and we will expedite your care. Otherwise, bear with us over the next hour or so. We'll go through a few slides. We'll talk about BPH as a disease state and do a sort of a high-level review of how we look at this disease and how we try to help our patients. This is a educational event. I'm not giving any direct medical advice to anybody here. We have excellent urologists up and down the Front Range, and I highly recommend that you discuss any of your urinary issues with your urologist, all of whom are perfectly qualified to deal with BPH. Just a little bit about Colorado Urology. We're the largest premier urology group in the Front Range. We take care of really the vast majority of urologic patients in the Denver metro area. And our mission is to make sure that every patient has superior experience and make sure they get state-of-the-art care. We, in our practice, have close to 30 urologists, almost 20 advanced practice providers. We have a couple of radiation oncologists, interventional radiologists who work very close with us, and they're an integral part of our BPH care. We work out of 12 offices and actually more with several ambulatory surgery centers, interventional radiology suite, and prostate cancer centers. So we've kind of created this comprehensive urologic practice where we can take care of our patients start to finish and all within our infrastructure. As you see on the map, we are where you are. And so, the goal with Colorado Urology has been to meet our patients in their neighborhoods and take the same excellent state-of-the-art care to where patients live, minimizing the need for you to travel and seek expertise away from where, the comforts of your neighborhoods. First and foremost, what is BPH? So the BPH stands for Benign Prostatic Hyperplasia, and the definition really says everything about the disease. It's a benign condition, non-cancerous. It happens in the prostate, and hyperplasia means that the gland gets bigger. Prostate is a reproductive organ. Its function is to produce and transport semen. And once a man is done having children, quite frankly, he does not need his prostate. Prostate by itself does not produce any hormones, and in and of itself is not a sexual organ. Unfortunately, the prostate is a sort of a tragic organ in that it grew around the urethra. So when we go to urinate, if this is the bladder, the prostate sits underneath the bladder and before the bladder connects to the urethra. The urethra actually goes through the prostate, and the prostate wraps around the urethra like a donut wraps around its core. And and it's there because, obviously with sexual function, ejaculate needs to be deposited into the urethra. It really didn't have to be the way it is, but unfortunately, it is developed this way. And when the prostate becomes diseased, it affects things like our urinary system, and of course, it can become cancerous. So I always tell my patients there's two things that happens to our prostates as we get older. It either gets bigger or tighter, which will result in urinary difficulties or can result in urinary difficulties. And conversely, the prostate can become cancerous, which is the prostate cancer that we all dread. One does not necessarily rule out the other, and one does not cause the other. So you can have BPH with no cancer, you can have cancer with or without BPH, and you can have one condition or the other. BPH does not lead to cancer, and so it's really important to keep that in mind. Now, of course, when you see us, urologists or your doctors, we want to work you up for both because as part of the process, obviously, we have to make sure that you don't have, prostate cancer. So why does it happen? Why do our prostates get problematic as we get older? And frankly, almost 90% of men by the time we reach our 80s have BPH. About half of men by the age of 60 are affected. So if you see me walking away from this conversation in about half hour, you know about how old I am. But aging and hormones are the main drivers. We don't quite understand how it works, but we know that prostate tissue grows in presence of testosterone. And certain factors like family history, obesity, diabetes can raise the risk of BPH. Growth doesn't always cause symptoms. So sometimes people have, very large prostates, but they have minimal urinary symptoms. Sometimes people have small prostates and they have a lot of urinary difficulties. The prostate is a dynamic organ, and as we urinate, the prostate is supposed to relax and allow urine to go through. Sometimes small prostates can be quite obstructive, especially in younger men. When we develop urinary tract symptoms, it's often broken down into obstructive and irritative symptoms. So your doctor will ask you questions like, "Hey, how's your flow? How do you have hesitancy? Does it take a while for you to get your stream started? Is your stream intermittent? Do you stutter when you try to pee?" These are all obstructive symptoms. Do you have urgency and frequency, and do you get up at night to pee? These are the irritative symptoms. And oftentimes, an obstructive prostate can irritate to the bladder to the point where the bladder can't hold as much and it has to go frequently. So these symptoms go hand in hand. In our practices, in standard urology, we call this constellation of symptoms LUTS, lower urinary tract symptoms. So you may hear your doctors say LUTS, or you may see in their records they mention LUTS. The idea behind LUTS is that people develop urinary difficulties not just because of the prostate. You can also have an overactive bladder with or without obstruction from the prostate. The bladder is supposed to hold urine, and it's supposed to hold urine quietly until it's full. And then when it's full and it's convenient, it's supposed to squeeze so you can urinate. Well, that doesn't always work that way, right? So the bladder doesn't always hold urine quietly. The bladder sometimes becomes overactive, which causes urinary frequency and urgency as well. And so our job is to try to differentiate BPH versus urinary or overactive bladder leading to urinary symptoms. And that's why we put this all under the LUTS sort of overarching diagnosis. The question always is, well, when do I need to see a doctor? I mean, we all start to suffer slowly as we get older. And the question always is, well, when do I need to see somebody? Well, the answer is very simple. First of all, just because you go to a urologist doesn't mean that you're going to end up on a medication or you're going to have a procedure. So don't be afraid to come and see us. When these symptoms become sufficiently problematic, where they disrupt your sleep, work, or quality of life, if you ever see blood in the urine, if you ever have pain or burning when you urinate, if you obviously are unable to urinate, And if you get frequent urinary tract infections, these are times when you really should seek attention. Now, right around the age of 50, it's not a bad idea for men to establish a relationship with their doctor. And generally speaking, it's your general doctor. They need to check your PSA to make sure there's no prostate cancer, oftentimes with or without a rectal exam. So that's sort of the baseline entry for a lot of men into the healthcare system. And then sometime thereafter, probably establishing care with a urologist, especially if these urinary symptoms are starting to rear their head. Um, how do we diagnose BPH? So there's a series of data points that we as urologists like to gather to not only evaluate a patient for their symptoms and the source of the symptoms, but also to rule out bad things like cancers and stones and other things that may be concurrent with the urinary symptoms. The first thing you'll do is a symptom questionnaire. It's kind of a silly questionnaire. It's 7 questions. You have, an option of five answers, and it's one that you sort of get inundated with. Every time you come to the office, you have to fill it. A lot of patients sort of get tired of having to fill that questionnaire. It is a validated questionnaire, and it is a integral part of how we evaluate your symptoms and how we monitor your symptoms. So please pay attention to the questions. Please answer them as accurately as possible. We really do care about that, and I'll show you the questionnaire here in a minute. You will get a physical exam. Now, a lot of doctors have gotten away from doing a rectal exam to check the prostate. I believe most urologists still believe in doing a rectal exam. And if you are wondering why your doctor did not do a rectal exam, you can always ask them. There's times we don't do an exam because of various clinical scenarios, and you're welcome to ask and say, "Hey, doc, I noticed that you didn't do an exam of my prostate. Explain to me why." I personally think it is super valuable for us to do a prostate check, at least on the initial visit. We don't have to do it every time. But obviously, it's good to see what the prostate feels like, make sure there's no masses or lumps or bumps. And believe it or not, I've a time or two have found other cancers like rectal cancers doing this exam. We always do a urinalysis, so we ask you to collect your urine at the beginning of the visit. We run the urine for a test to make sure that there's no blood, that there's no infection, and there's no protein or glucose in the urine. We look at a lot of different things on your urinalysis. People who have diabetes, whether they know it or not, can spill a lot of sugar in their urine, and that can cause a lot of urinary difficulties as well. And of course, if we see a lot of protein in the urine, that can be a sign of kidney disease, and we have to make sure that you get to see your doctors and nephrologists and other people to make sure you don't have kidney disease. And then we look for blood, make sure that there's no blood. Blood can be a sign of a lot of different illnesses, and it's important for us to make sure of that. And of course, an infection, whether symptomatic or not, can cause a lot of urinary difficulties. So the urinalysis is quite important. As part of your testing, we also do a PSA test. And the PSA is to just a very cursory screen to make sure that there is no prostate cancer. And so that usually is part of the testing. We then usually at subsequent visits have you do a flow test, and we'll look at examples of that. We have you do some imaging, like an ultrasound, to evaluate the prostate, the size, the shape. And we oftentimes do a cystoscopy, a look in the bladder, which at first can be a little bit intimidating. But I, always tell my patients, I say, it's not the greatest day in your life. It's not the worst day in your life. And just so you know, the procedure doesn't hurt me one bit. That's a joke. But it's a procedure that can be just slightly uncomfortable. We put some numbing gel inside the urethra. We run a very small camera in and take a look inside. It is really important. Just today, I was doing a cystoscopy to evaluate a gentleman for urinary issues. No blood in the urine, no risks otherwise. And indeed, he had bladder cancer. And the bladder cancer likely is the contributing cause of his urinary symptoms. So, very lucky that we looked. This is a cancer that would have grown and would have caused him trouble. So, if your doctor suggests a cystoscopy, there's a reason for it. The questionnaire, as we talked about, is a series of questions. The most important question, frankly, is the one on the bottom that says, if you were to spend the rest of your life with your symptoms, no better, no worse, how would you feel? And this question is intended to engage our patients in the decision making because, sometimes objectively things may look bad, but a patient may say, you know what, I'm not bothered. I don't want a medicine. I don't want a procedure. I don't want anything. And then we say, okay, fine. As long as you're not in any danger, we can monitor your symptoms. So that bottom question we oftentimes use to gauge how badly you are affected from a quality of life standpoint and how aggressive we need to be in pursuing a treatment. And when we do an ultrasound on the left side, you see sort of this picture of an ultrasound. The black part is the bladder. The prostate sits underneath the bladder. And in this case, the prostate has a growth that goes into the bladder. And we can identify that oftentimes on ultrasound and also on cystoscopy later. And this growth acts like a ball valve. So when the bladder tries to empty, the growth can fall into the urethra and cause a blockage. Cystoscopy is where we look inside. These are the lobes of the prostate. So if you want to orient yourself, this is sort of looking down the barrel of the urethra, and we're looking at the beginnings of the prostate. These are what we call the lateral lobes of the prostate, which have enlarged to the point where they are touching. And when your bladder is trying to empty, it has to squeeze the urine through these lobes, push the lobes out of the way so urine can get through. As a result, a normal bladder, which looks like this, can over time become thickened. You see these bands of muscle that go across. And then eventually the bladder wall can look like something like this, where the muscle gets atrophied and these bands of tissue start to show up. This is an unhealthy bladder. So, as urologists, our job is to attend to your urinary symptoms, make your quality of life better, but also to attend to the health of your bladder. Because while there's a lot of things we can do to open up the prostate, there's not much we can do to make the bladder work better. And once the bladder is blown, once it quits working, not much we can do. You can become catheter dependent. Now, this is not a common event. I don't want to scare you, but it certainly is something that we as urologists stress about because we don't want you to 5 years, 10 years, 20 years down the line become catheter dependent. And at that point, there's not much we can do. And this oftentimes happens as a result of untreated obstruction. This is a bladder that's working hard, and over time, it gets tired and quits working. There's a bunch of studies we do to try to evaluate the flow rate, and there's different studies, different options. Euroflow, Eurocuff, urodynamic testing. Most recently, this new test we do called Glean. And they have different ways of looking at the same thing, which is to try to figure out how hard your bladder is working to try to empty. And so, for example, the Eurocuff plots the flow that you're able to generate against the pressure that your bladder has to generate to get the flow. And so a 20-year-old guy lives out here. He's got great flow, very little pressure. The bladder squeezes a little bit and urine comes flying out. As we get older and get more obstructed, the flow goes down, the pressure goes up. So the bladder is squeezing harder and harder and harder for a diminishing flow because of so much obstruction. Where we don't want to be is down here, where the flow is low, but now the pressure is low. The bladder has given up. And that's our job to make sure you don't end up there as we follow you longitudinally. Along the way, we are going to talk about various treatment options. And there is a whole spectrum of options available. In the old days, BPH was simple. It was have symptoms, go do surgery. And then medications came along and it was have symptoms, take medicines until medicines no longer worked, and then go do surgery. But those surgeries were oftentimes not very successful because the bladder was decompensated. That didn't work because we waited so long on medications. Now, with prostate cancer treatment, it almost looks like a you know, Chinese restaurant menu. We have a million different options, and it gets really confusing because not only are these, very heavily advertised in online and on TV, etc. But your urologist is going to have a lot of different options, and they're going to give you a brochure and they'll say, well, you can do one of 12 different things. And the big question is, well, which one is best, and why would I choose one over the other? And tonight we're going to talk about that a little bit and try to help you sort of at least guide which way you ought to be thinking. But in general, we always start with lifestyle and dietary lifestyle modifications. Watchful waiting, meaning that if your symptoms are mild and there's no objective evidence of any bladder problems, we can certainly keep an eye on it for a little bit before we get you started on medications. During that time, a lot of times people take supplements like saw palmetto and whatever other supplement that the internet throws at you. There's no great evidence that the supplements really work, although we have patients daily who tell us that the supplements do work. And I personally, doctors are trained in the Western tradition. I'm not one to discount the wisdom of Eastern medicine and thousands of years of experience with herbal therapies. And so, who are we to say that that doesn't work? So, if you're interested in that, if that's something that you want to try, most certainly try it and work with your doctor and see if it's something that's working for you or not. Beyond that, we usually start people on medications. If medications are not effective or people don't want to be on a medication, we have the option of either minimally invasive procedures or some kind of a surgical procedure. And we're going to talk about that in a minute. In general, the big picture is that as you become more invasive, as you go from lifestyle, watchful waiting to medications, to minimally invasive therapies, to surgeries, the effectiveness of the treatment tends to be better, right? So surgery ultimately works better than anything else. On the flip side, the recovery also becomes a little bit more difficult, and there could be some potential sexual side effects. So it is a trade-off between efficacy and durability, because again, surgeries are the most durable option we have available. Durability meaning that you don't have to go back and do something else within a year or two or three or five. Of course, the surgery is going to be more durable than any other treatment. But you have a trade-off of recovery. There's a little bit more commitment up front, and then potentially some sexual side effects. And so you and your surgeon are going to have to decide between you what your priorities are. What are your values? What fits in your current lifestyle and desires? I have patients who say, you know what, I'm really busy. I work. I just can't, take a week or two off for recovering from surgery. Plus, I'm very sexually active. I want to be able to preserve my ejaculation, and therefore I don't want to have surgery. And then we find something that is less invasive and with quicker recovery, as long as they are appropriate for understanding that down the line we may have to do something else. And so we'll go through that a little bit more. So watchful waiting, lifestyle changes, we talked about a little bit. While you're doing this, of course, limit caffeine and alcohol. Those are diuretics. They cause you to go to the bathroom more often, and they can be quite irritating to your urinary symptoms. Be cautious with decongestants and antihistamines, cold medicines. These can worsen your urinary symptoms. Try bladder training, double voiding, meaning that you go to the bathroom, you pee, you're done, relax. Try to go a second time. Don't zip up and walk away, because that's when you get dribbling, right? Your bladder's not totally empty. There's urine left behind the urethra, and you dribble and leave a mark on your pants. And so double voiding is a common technique people use to try to sort of empty as best as they can, minimize the post-void dribbling. Timed voiding is one where we say, hey, don't wait too long, right? So when you feel you don't want to go too often, you don't want to go to the bathroom at every signal, because then you can become frequent, and it can be quite bothersome. But also, don't wait 6 hours or 8 hours, or really put off your urination. When the bladder needs to go, it needs to go. And so within reason, accommodate your bladder and work with it. Regular checkups, of course, to make sure things are not getting better. And we already talked about supplements. Medications, there's two general classes of medicines. The first class of medications are called alpha blockers. A classic example is tamsulosin or Flomax. There's alfuzosin or doxazocin, and there's a bunch of other zosins. And these are all alpha blockers. The way they work is they relax muscles in the prostate and the bladder neck. And so when those muscles relax, the prostate can stretch when you're urinating. It accommodates the urine more easily, so urine can flow through more easily. These medications, are pretty effective, and they're also very quick. So usually within a few days of starting the medication, people notice an improvement. Now, because they relax muscles, they can also relax the muscles in your blood vessels. And so people can have a drop in their blood pressure. So if they're taking a lot of blood pressure medications with this medicine, that can be a little bit, that has an additive effect. But also, what happens is if you stand up suddenly, your blood vessels can't keep the blood from rushing away from your heart because your extremities are relaxed. Those blood vessels accommodate urine or accommodate blood. And so people get dizzy when they stand up suddenly. That usually happens a little bit more the first few days after you start the medication. Sometimes the body adjusts to it and sometimes it doesn't. If you get dizzy and if it lasts more than a few days, it really is not safe, right? So we don't want you to get dizzy and fall, especially middle of the night. I tell my patients if you get up middle of the night to go to the bathroom, perhaps sit at the side of the bed for a second or two, sort of catch your bearings before you go. Or if, for the real elderly and people who have a really hard time with mobility, get a commode next to the bed and pee in that instead of having to walk across the room, potentially getting dizzy, etc. So safety is definitely very important. The other thing that happens with these medicines is it can cause a little bit of nasal congestion, like you got kind of a cold. And it can interfere with ejaculation. You're going to hear this a lot. It's called ejaculatory dysfunction. You still have an orgasm, just no fluid comes out. And that's because the prostate is relaxed, the bladder neck is relaxed, the fluid sort of stays in that area instead of shooting out the penis. And the next time you urinate, the fluid gets washed out. It's not a dangerous condition by any means. It's not a big deal. And it reverses itself once you have stopped taking the medication. Most men don't care about it too much, but some do. And if it's something that really bothers you, of course, we need to tailor your treatments, whether surgical or medical, to minimize the risk of that happening. Um, these medications don't actually shrink the prostate, they only relax it. Now, there's a whole different class of medicines called 5-alpha reductase inhibitors, like finasteride or dutasteride. These medications block hormones within the body and they physically shrink the prostate. It may take about 3 to 6 months for full effect. So it's not a medicine that you notice an improvement right away. And it's not a medicine you turn on or turn off. It's just something you got to take and stay on for it to be effective. It's best for bigger prostates. And because it's hormonally active medication, it can reduce libido and lead to some erectile issues. And for some men, it actually persists. Rarely, it can actually cause breast growth and tenderness, which is kind of a bummer when it happens. So in general, these medicines are well tolerated. They definitely have a place in treating men with urinary symptoms, but with caution. And what's most important is if you take these medications, finasteride, dutasteride, your PSA is cut in half by mistake. So when you have your PSA tested to make sure you don't have prostate cancer, you always have to double the number. It's a corrected number that needs to be taken into account when trying to assess the risk of cancer. A lot of times, patients and sometimes even physicians forget to do that, and it puts people at unnecessary risk. So keep that in the back of your mind. If you're on these medicines, always double your PSA. And of course, combination therapy. So for somebody's got a big prostate, oftentimes we put them on both medications and go from there. The problem is this whole concept of polypharmacy, and this has been recognized for a long time. In the September 2017 edition of Consumer Reports, they actually talked about it a fair amount. They said What we don't realize is that we keep putting people on more and more and more medications. And while these medicines individually may be tested for safety, the medications in the particular combination that a patient is taking, they may not be tested in combination and may not be necessarily safe. On top of that, we really don't know what happens when people are on these medicines for life. And so um, that's why in medicine in general and in urology specifically, we really pride ourselves in our ability to fix problems instead of covering the symptoms with medications. And that's why your doctor may talk to you about alternatives to medications. And as if I had paid Consumer Reports to write this, they did write on the right. It says, follow our doctor approach plan to take fewer drugs, avoid dangerous side effects, and feel better. That is the motto of Colorado Urology. So polypharmacy is a big deal. Now, beyond medications, if medications don't work, if you don't want to be on a medication, or if you have too many side effects to them, we can talk about a lot of minimally invasive procedures. Now, in general, these procedures are considered when lifestyle changes and medications aren't enough. These are minimally invasive in that they are often done either in the office or as a day procedure with or without anesthesia. And if it's with anesthesia, it's usually minimal and quick anesthesia. A key advantage of this whole class of procedures, calling minimally invasive procedures, is that they tend to preserve sexual function, ejaculatory function, better than surgeries do in general. So again, go back to less invasive, minimally invasive procedures are better tolerated, quicker recovery. They may not be as effective and they may not be as durable. So that's sort of the trade-off that we have to accept and we have to go after. But a lot of people choose minimally invasive therapies because they don't want to commit to a surgery. They don't want to have the sort of the recovery that comes with surgery, and they don't want to potentially suffer any ejaculatory or other sexual side effects. And there are, again, a million different options, and it seems like something new is coming every day. In our practice, we sort of do a lot of procedures like UroLift, Resume, iTind. We're starting to do some OptiLume. We'll talk about that. And of course, prostate artery embolization has found its way as the sort of probably the primary minimally invasive therapy for treatment of BPH. And we'll talk about these here in just a minute. There are other options available, and which one you do largely depends on sort of your research, your physician's comfort level with various procedures. Interestingly, most of these procedures have equal outcomes and equal efficacy and equal sort of durability. And so which one you do largely depends on size and shape of the prostate and what your surgeon is most familiar with. But let's talk about them a little bit. So the UroLift is a clever procedure. What we do is we look inside the prostate, and as you see in this middle picture, these are sort of these obstructive symptoms that cause a blockage. And then what we do is we place these permanent implants in the prostate. It's a twine that goes in and it deploys an anchor on the outside of the prostate, and over a suture that goes through the prostate, it places a second clip on the urethral side, and it squeezes the prostate tissue between these two clips over the string. And we put anywhere from 4 to 6 or so of these implants to open the prostate channel. And so on the right side is sort of an ideal outcome. They don't always look like that, but ideally you sort of pull the prostate tissue apart to the point where you can peer into the bladder. And as you can see, this is a very happy bladder because now it can push the urine through quite easily. Again, doesn't always look like that, but that's sort of an ideal outcome of it. It's done as an outpatient procedure. It can be done in the office. It can be a little uncomfortable. So a lot of times nowadays we do them under a quick anesthetic at the surgery center. You may or may not go home with a catheter. A lot of my patients go home with a catheter just for one night. There's a fair amount of irritation. As you can imagine, the first week the prostate is not happy. So you'll have some frequency and urgency and some blood in the urine. That's a common theme with all prostate procedures. But usually in that sort of 7 to 10 day mark, the prostate has healed enough that people start to notice an improvement, and the improvement usually gets better until a few weeks after surgery, even a few months after surgery. Um, Biggest advantage, there's no risk of erectile or ejaculatory side effect with this. It's a little bit complicated because it's a foreign body. It's an implant we place, so your doctor needs to be well versed on how to place them, make sure they place them in the right place, and it doesn't to go in the bladder or in places where it doesn't belong. But really, if your doctor within Colorado Urology offers you UroLift, our doctors are well trained, well vetted to make sure that they can do a good job with that. Most people, return to regular activity within a few days. And again, it really depends on the size and the shape of the prostate to see if you qualify for this procedure or not. On the right side, in all these slides coming up, there's some quick facts. So, we can do this for, even sometimes bigger prostates, but really, honestly, most effective as prostates in sort of that mid range, 40 to 60 grams or thereabouts. Normal size prostate is about 30 to 40. So you'll hear us refer to grams as a surrogate for the size of the prostate. It also sort of the same as cc's or milliliters. And normal prostates about 30 or 40. Prostates get bigger, 50, 60, 80. These are moderately enlarged prostate. Once they get to be over 100 grams, they are quite enlarged prostates. Prostates can get very big. They can be 200, 300 grams. By then we are looking at some significant interventions to try to make it better. So you'll hear this reference to grams, and then various procedures are qualified to take care of various size prostates. So again, it's not one fit for all. And then, the way we monitor the outcomes of all these procedures is we see the symptom score, that questionnaire that you fill out. We see how much improvement you get in that. We measure your flow rate to see how much better the urine comes out in terms of, sort of the flow that comes out. And then we monitor what percent of people will need to be retreated, either with medications or surgeries, over about a 3 to 5 year period. And so you see these statistics referenced. And so for UroLift, for example, on average, people get about a 30, 35% improvement in their symptom score, which is fairly significant. It's much better than medications. They get about a 40% improvement in their flow rates. They come back and say, yeah, I can, the urine comes out better and it's, stronger. And so that's the improvement of flow rate. When you look at it over 5 years, about 13% of people go back to having to have another procedure. Again, these minimally invasive procedures are not always very durable. So about 13, 14% of people have to do another surgical procedure, and another, quarter of people, 25% of people are back on medications within the 5 years. Again, the effects of the procedure can wear off because the prostate continues to grow and it overwhelms the force that those implants can provide. So that's UroLift. Good procedure. A lot of us do it. And for the right size prostate and for the person with appropriate expectations, it's a great way to get some relief and preserve ejaculatory function. Resume. This is a clever device. What we do is we look inside, and the device puts a small needle into the prostate. We inject steam into the prostate. The steam heats the tissue, and the heated tissue over time can shrink and sort of get absorbed back into the body. It does a great job of removing prostate tissue and really actually, physically opening up the channel. It's a little bit more, if you will, to do up front. It's a little bit bigger commitment because you got to kind of wear a catheter for about 3 to 5 days afterwards, because the prostate kind of swells up and gets irritated from the steam, and we got to wait a few days for it to sort of go down. It can be done in the office. It can be done at the ambulatory surgery center. Just like anything we do, there's temporary discomfort from the procedure, maybe some pain. A catheter is needed. And then the symptoms, just like all other prostate procedures, get worse before they get better. Now, with the Resume, the symptoms tend to be bothersome for quite a few weeks, as opposed to UroLift, where within a week or so, 10 days, you're back to sort of improved symptoms. With Resume, it can take a few weeks longer. And that's partly because it's actually working. It is removing prostate tissue, and the prostate, as it's sort of, that tissue that's treated as it's dying and getting reabsorbed, of course, it causes a lot of irritation to the prostate. When I do resume on my patients, I say, don't judge me by how you feel in the next few weeks. Judge me by how you will feel in 3 months. And at 3 months, a lot of these people come back and say they're very happy, improvement in their symptoms. As you see, they have a 48% improvement in their symptom score, 44% improvement in their flow rate, so similar to the Urolift. The good news is, as far as retreatment, is about 4% of people need to undergo another surgery, and about 17% of people need to be back on medications within those 3 to 5 years after the procedure. So the outcomes on this are actually similar to a lot of the surgeries we do. The advantage being that ejaculatory dysfunction happens in less than 5% of people, 0 to 4%. And it can be done for really, a lot of different size prostates. But again, when a prostate gets to be really big, like 100 to 150 grams, at some point it gets silly. Like you can't put enough steam in the prostate to really, make it effective. So I don't really do it for very large prostates, but for people, with prostates up to about 100 grams, I think the resume is very reasonable as long as the patient can put up with a few days of a catheter and maybe a slightly longer recovery, a little bit more patience, but they can get surgery-like outcomes without having to do a surgery where we trim out the prostate. iTind is a newer procedure. We have a couple of experts in our practice. Dr. Anderson up in our Superior office is sort of a regional expert and probably has done more than almost anybody else. The way the procedure works is we place a temporary implant inside the prostate. So we put sort of this basket that expands inside the prostate. We leave it in for about a week. You come back and we take it out. And by expanding the prostate, it creates pressure points along the prostate, and it scars the prostate in sort of a more open configuration. It's all done, in the office or at the ASC. The implant is removed in the office 5 to 7 days later, and it can take, again, up to about 3 months to get full symptom relief because the prostate can get, somewhat irritated from this pressure. But the outcomes are actually pretty good. No ejaculatory dysfunction, 45% improvement in symptom score, almost doubling of the flow rate, which is a surprisingly large number. Again, I don't do this procedure. I don't have personal experience with it. But when I looked at the data, the flow rate improvement is quite quite impressive. And I have to, give them credit for that. And about a 10% retreatment rate. Now, they didn't break that down into what percent went back on medications. I bet you a larger number of these people are back on medications. I just don't have that data. So, and it works for sort of the medium-sized, small to medium-sized prostate. So 25 to 80 grammer, certainly iTind is an option. But then, as you can see, you're sort of starting to see the theme, which is that Urolift, Resume, iTind, and this next one, Optilume, we'll talk about that. They all overlap in their indication in terms of the size of the prostate. They all overlap in terms of their efficacy. All of them have about a 50% improvement in symptom score, 40 to 100% improvement in their flow rates. They all have about a 10, 20%, 30% retreatment rate. So they all look very alike in terms of their outcomes and in terms of their indications, but they're just different technologies. There's more than one way to skin a cat. And so I don't know that I would get too caught up in one over the other procedure. I would trust your surgeon and see what they're comfortable with and ask them, why they chose whatever it is they do, Urolift or Resume or iTind, why they chose that over the other procedures. And oftentimes it's frankly, their comfort level with the procedure. The outcomes are about the same. Optilume is a temporary balloon. So what we do is we place a balloon in the prostate. The balloon inflates and sort of, fractures the prostate tissue and opens it up. And it puts a medication into the prostate that, sort of keeps the prostate from scarring back down. It's done in the office or usually at the ASC, at the ambulatory surgery center. You go home with a catheter for about 2 or 3 days. Again, a fair amount of irritation, blood in the urine for the first few days to, week or so, similar to all other procedures. Full symptom relief can take upwards of 3 months to be noted. And you see, again, 20 to 80 gram prostate, low ejaculatory dysfunction, 4%. Same theme as all the other minimally invasive procedures. The one minimally invasive procedure that is sort of standing out as very different is prostate artery embolization. This is a radiology procedure. This is not a surgical procedure, and it's not done by urologists. When it first came out, our radiology colleagues came out with it, probably over a decade ago. Most urologists were very reluctant to accept this as a valid or reasonable alternative to surgery. Of course, we're surgeons, we like to do surgeries. Who are these radiologists who want to do our work? But as they have done more, and as we've seen the outcomes, and as they've gained experience with the procedure, and as we have gotten better at picking the patients who are likely to do well, PAE has shown itself to be a very reasonable, minimally invasive alternative. Again, this is not a surgery. It's not going to have surgery outcomes just like all other minimally invasive options don't. But it is an alternative to a minimally invasive procedure that does not involve an anesthetic. It doesn't involve anything going through the penis. It doesn't involve a catheter post-procedure. And recovery is exceedingly fast. So this is a procedure that's done by our interventional radiology colleagues. They do it usually under a little sedation in their procedure center. They gain access to your blood vessels through either your groin or the wrist. They find the arteries and they can put tiny little catheters through those arteries, and they basically take those catheters and they follow the arteries all the way to the tiny little arteries that feed the prostate. And there's usually, a couple, 2 to 4 main arteries that they find, and they put little beads inside those arteries and plug them. So they basically decrease the flow of blood to the prostate. It doesn't eliminate flow of blood to the prostate. You don't want to totally kill it. But certainly, if you have less flow of blood to the prostate will relax, the prostate will shrink by about 20 or 30%. And with it, symptoms tend to get better. Recovery is very quick. It's just a little, skin incision or, a little poke in the skin, like you're getting an IV. And, the entry into the artery has to heal. So, we ask you to take it easy for a day or so. But most people within about 24, 48 hours are back to doing whatever they want. The prostate will be pretty irritated for that first week or 10 days. Again, similar, very common theme. So you'll have frequency, you'll have urgency, you'll have a little bit of, pain in your pelvis. And then usually at that sort of 7 to 10 day mark is when the prostate settles down and people start to notice an improvement in their symptoms. Flow improves, frequency and urgency goes down, getting up at night goes down, and oftentimes we can help people get off medications. Again, up to 3 months before we judge the outcomes of the procedure, because symptom improvement can take up to 3 months. Look at the data. You can really do it for any size prostate. It works better for maybe larger prostates, but there's no size limit. Ejaculatory dysfunction happens in about 10 to 15% of patients, so it's maybe a little bit higher than a Urolift or a Resume, but it's very acceptable. And the results are great. I mean, symptom improvement, 50%, flow rate plus 30%, and retreatment rates of, at about 18 to 30% surgical or medical within those first 3 years. And so I always tell my patients, they say, well, doc, what should I do? PAE, do I do a Urolift, do I do whatever? And I say, just judge by, the size and the shape of the prostate and what we're trying to accomplish. But if your prostate is a candidate for a PAE, not all prostates are, not all blood vessels are, not all, et cetera, especially if you have health issues where an anesthetic could be, complicating and could be dangerous to you, I think a PAE is a very reasonable place to start. Remember, as surgeons, we are on standby. We can always operate on the prostate. We can always fix the problem. But let's give these other options a chance first and get to surgery when we need to. Um, Now, surgery is needed for a lot of different reasons, right? More severe symptoms, very large prostates, complications like kidney damage, bladder stones, recurrent infections. By the time somebody's really in trouble, they truly need surgery. It's also an option if medications and less invasive procedures don't work. And frankly, sometimes patients say, you know what, all of this is good. I don't enjoy going to the urologist. I don't want to keep coming back. I don't want to see you again. Let's do a procedure, even if it's a surgery up front, that gives me the best long term outcomes, the best results. And certainly with surgery, we can give you better long term durability than any other option, including these minimally invasive procedures that we do. So this is not, just a knock against radiologists. It's against a lot of the minimally invasive stuff that we do. But in return for surgery, it involves an anesthetic, involves possible hospital stay, longer recovery. You'll have a catheter for a few days, 3 to 7 days, maybe sometimes longer. You'll have blood in the urine. You'll have frequency and urgency, and you have to wait for things to recover for upwards of a few weeks afterwards. And anytime you invade the body, there's always a potential for complications like damage to bladder, damage to the ureters that drain into the bladder. There's risk of scar formation inside the prostate or the urethra as a result of the instruments that are inserted. And so it is not a risk-free type of a procedure. In return for that upfront price that the patient pays, they will, generally speaking, have more durable and effective outcomes. Now, in the surgical world, it all sort of is the same, right? So the goal of surgery and the end result is that we remove prostate tissue. So you take the donut hole, you make it bigger, so urine can flow through more easily. The question is, how do we do that? Do we use an electric loop to shave the inside of the prostate? That's the traditional TURP. We'll talk about that. Do we use laser to melt away the tissue, or potentially use laser to enucleate, meaning that you take the sort of the core of the prostate all in one piece using a laser energy called HOLEP? Do we do aquablation, which is a water jet that trims out the inside of the prostate? Or do we go from above through the abdomen, through the bladder, to do a simple prostatectomy where we enucleate the prostate? It's like taking an orange and removing the meat of the orange, leaving behind the rind. That's what a simple prostatectomy is. And what we do largely depends on the size and the shape of the prostate and the goals, right? So a TURP has been done forever. It's probably one of the oldest urology procedures. The technology has changed a lot. The type of electric current that we use, the generators that we use, the instruments that we use, they're all significantly better than they were even 10 or 20 years ago. But the end result is the same, which is the gold standard of going in and removing excess prostate tissue through the urethra using either electric or laser energy. There's no external incisions. A lot of times people go home same day. Sometimes people spend the night in the hospital. They have a catheter in for 1 to 3 days. And it's exceedingly well studied for decades. There's long-term outcome. There's lots of experience. Any urologist worth their weight knows how to do a TURP very well. That's what we do. That's what we train. And that's what a lot of us are really good at. The results are amazing. I mean, there's 80% improvement in symptom score. Remember, compared to minimally invasive options where we see a 30 to maybe 50% improvement, we see 80 plus improvement in symptom score, 100% improvement in flow rates. Most importantly, retreatment rates are low, 7% surgical, 15% back on medications within those 5 years. However, there's trade-off, right? So anytime you mess with the prostate, there's a potential risk of developing urinary incontinence. We can affect the continence mechanism, the sphincter that holds the urine, and somewhere between 1 to 5% of people can develop urinary incontinence after a surgical procedure, regardless of which surgery we do. And ejaculatory dysfunction happens in a good majority of people who have a TURP. about 50 to 70% of people develop ejaculatory dysfunction. Again, they still have an orgasm, just no fluid comes out. A different way to do this, TURP is to go in and do a whole lab procedure. At Colorado Urology, we actually have a number of experts who really like doing whole lab procedures. Whole lab is where they use laser. So again, they go through the penis and they use laser to get into the space between the capsule of the prostate. This is the sort of the rind of the orange, if you will, and the meat of the prostate and all the obstructive tissue. They get in that space and they enucleate, meaning that they remove the entire inside of the prostate in one piece. They mobilize that, they drop it into the bladder, and then they use a device to sort of remove that piece by piece from inside the bladder. Everything is done through the urethra. It creates a giant path, and it really opens up the prostate nicely, probably better than most anything else that we do surgically. Results are great, 80+% symptom improvement, 100% or above flow rate improvement, and relatively low retreatment rates, 4% surgical, 11% medical over 5 years. It kind of makes intuitive sense. We're removing a lot of tissue, and so here we are. Problem is, complications. We're messing with the prostate, risk of incontinence, and of course, risk of ejaculatory dysfunction is much higher because we're removing so much tissue. Aquablation is where we use a water jet to do this. We use ultrasound as a guide. We identify the parts of the prostate that we don't like. We identify the parts of the prostate that we want to keep, meaning the bladder and neck, and that's sort of that internal sphincter, and the ejaculatory ducts where ejaculation happens. We know we can see them on ultrasound. We design the procedure so those areas are preserved, and then we core out the center of the prostate using a water jet and a robotic guidance. The procedure is done at the hospital, sometimes go home same day, sometimes spend the night in the hospital. And the key goal and the key advantage of aquablation is better preservation of sexual function. So the risk of ejaculatory dysfunction is really only about 10% or a little bit less. And risk of incontinence is exceedingly small because we're able to preserve the sphincter muscles so well. So it really stands out as a nice option, nice alternative to other surgeries. Again, excellent improvement in symptom score and flow rates and low retreatment rates. So aquablation sort of has carved out a nice place for itself in this process. And then, of course, simple prostatectomy is where we go through the abdomen. We achieve a similar result to that HOLEP where we enucleate the prostate and remove the inside. It's really best for people with very large prostates or people that, for whatever reason, have to have an abdominal type of a procedure. Great outcomes, very good durability, but high ejaculatory dysfunction, just like all else. So when you compare your options, and I really urge you to sort of go over this pro and con table with your surgeon to say, what are your goals? Is your goal sexual preservation, even if it's not as durable, even if it's not as effective? Then we go, the minimally invasive route, and PAE is a great alternative. If the goal is, hey, maximal efficacy, maximal durability, then we go the surgical route. Within the surgical world, if the goal is to preserve ejaculatory function, we sort of go towards the aquablation. So this is the algorithm that we use, and this is the algorithm you should use as you go through that. When you see your doctor, again, talk about your severity of your symptoms and really identify your goals and share with your doctor what your goals are, what your desires are, and what is it that you're trying to accomplish, so they can tailor the treatment to sort of what you like. Key takeaway: BPH is common. Treatment ranges widely. Right choice depends on you. How your prostate shape and size and your stated goals. Talk openly with your doctor. At Colorado Urology, we're very lucky. We have over 50 provider urologists, APPs, radiologists who specialize in diagnosing and treating urinary issues. The multidisciplinary approach to urologic care is unique in that we have everything in-house. We work with 2 interventional radiologists who are our colleagues. They work with us. They're part of our group, and we freely share patients. and we make sure that you're properly diagnosed, understand all your options. We're here to see you where you live. You don't have to travel to the East Coast or the West Coast or North or South to get your care. You get it in your neighborhood. So if you're interested, obviously schedule an appointment to see us. See any one of our doctors that is close to your home. What I just described to you is provided by all 50 of us.